Hello everyone, I am Dr. Rajita, faculty of NEXTFELLOW. So today we are going to discuss with the pleura. So pleura means the coverings of the lungs. So we are going to discuss with the pleurae. So if you see the pleura, it is a double-layered serous sac which is plunged by the lungs. So you can see the outer lining, it lines the inner thoracic wall which is called as the parietal pleura, and the inner blue one which is along the lungs, which intimately covers the lungs along with the fissures, which is called as visceral pleura. And only at the hilum of the lung it is not covered by this pleura, where it leaves a gap for the passage of structures to enter in the lung and come out of the lung, which forms the root of the lung. So this is a basic introduction. And the gap between these two layers, that is the parietal and the visceral layer, this potential gap is called as the pleural cavity. It is called as the pleural cavity. And this visceral pleura and parietal pleura, they are lined by a squamous epithelium which is called as mesothelium. And this mesothelium secretes the fluid which fills this pleural cavity. So talking about its development to understand its reflection, we can see here initially the bronchi on each side. The trachea is dividing into right and left bronchi. At the terminal part of the bronchi, we see the lung bud starts forming. So these lung buds plunges the pleural cavity like this, like plunging into the balloon and making them into a double layered and reducing the cavity space into a thin potential space containing pleural fluid, which is called as pleural cavity. And this pleural fluid is mainly to reduce the friction during movements of the lungs. So we know that visceral layer, it gets reflected along the root of the lung. So when it is getting reflected, it extends beyond the root, forming a ligament called as pulmonary ligament. So we can see here, this is the pulmonary ligament. So this one is the pulmonary ligament, which is extending beyond the root of the lung. So this pulmonary ligament contains the loose areolar tissues and some nerves, sympathetic and parasympathetic nerves supplying the lungs. Actually, this pulmonary ligament, it allows the distension of pulmonary veins during venous return. So the usually veins are collapsed, we know. So during venous return, they have to get enlarged. So this pulmonary ligament provides the dead space for the pulmonary veins during venous return. Next, moving on to the surface, after surface marking about the recesses, normally between the parietal and visceral pleura, there is a thin potential space, which is filled with the pleural fluid. And this potential space gets roomy and bigger at the site of recesses. So recesses are the larger spaces between the parietal and the visceral pleura. So we know the parietal pleura, it gets reflected here beyond the lungs. It is getting reflected 2 ribs beyond the lungs, creating a recess between the costal pleura and the diaphragmatic pleura. So the costal pleura, when it gets reflected on the inferior side of the lung, what happens? This is called as costodiaphragmatic recess. This is called as costodiaphragmatic recess, which is the most dependent area of the pleura. So during pleural effusion, the fluid goes and easily accumulates in the costodiaphragmatic recess, and clinically it is present in the mid-axillary line. If you see laterally, this is the costodiaphragmatic recess. This is the lung tissue. So it is related to 8th to 10th ribs. Laterally it is related to 8th to 10th ribs in mid-axillary line. That is very important thing to note. Mid-axillary line, 8th to 10th ribs. And same thing on right and left side both. And next, talking about one more recess, that is called as mediastinal. This is called costomediastinal recess. This is costomedia. This is costodiaphragmatic. This is costomediastinal. So costomediastinal recess is along the anterior border of right and left lungs, where the costal pleura, that is the pleura which is along the ribs. It gets reflected over the medial surface of the lung. That is called mediastinal surface. So it is called costo-mediastinal recess. On the right side, it is not that prominent, where right border of the heart is located within this recess and during quiet breathing. Whereas on the left side, we can see already we have discussed about this cardiac notch. So because of this cardiac notch, we can see this costo-mediastinal recess is quite roomy. It becomes bigger here. Okay, it extends from the fourth rib to sixth rib. It extends between the fourth and sixth rib because of the cardiac notch. And clinically, this can be located by doing percussion. So by doing tapping percussion, we can listen to the sound. So usually the lung area gets resonated, and in this cardiac notch area we have heart here. So heart is located here. So the sound becomes from resonance to dull sound during percussion. That is the clinical importance. And remember one thing, it is located between fourth to sixth ribs and extending on the medial side, where the left anterior border of the lung is located within this costo-mediastinal recess. So costodiaphragmatic recess is more important, as during pleural effusion this is the dependent area and fluid gets accumulated. So clinically, costodiaphragmatic recess is quite important. As we discussed, it is between 8th to 10th ribs. So during tapping the fluid from the pleural cavity in pleural effusion, a needle is inserted between 9th and 10th ribs in mid-axillary line. It is inserted between 9th and 10th ribs in mid-axillary line, because we know this is located between 8th to 10th ribs in the mid-axillary line during quiet breathing, so to prevent the puncturing of the lungs. So the lungs won't be damaged in quiet breathing. Needle is inserted between 9th to 10th ribs. So here we can see again, this is the apex of the pleura, which is cervical pleura, extending 2.5 centimeters beyond the medial 1/3 of the clavicle. Then second point at the sternal angle, which we discussed here. Then the xiphoid process on the right side. Then eighth rib. So this is the first, second, third, fourth, fifth. This is fifth. This is sixth, seventh, eighth. So we can see 8th mid clavicular line, then 10th rib mid axillary line, and posteriorly 12th rib. It is related. So 8, 10, 12. And here on the left side, the cardiac notch is present 3 centimeters away from the midline. That is from the 4th rib to 6th rib. And the reflection is from the 6th rib to 8th rib again, then 10th, and posteriorly to 12th. So this reflection is very important in exam point of. This is called pleural tapping. So usually between 9th and 10th rib, the needle is inserted here, so preventing the damage to lung. So puncturing of the lung is prevented. So usually it is done from in the mid axillary line. This is the mid axillary line, needle is there. So during quiet breathing, it is inserted between 9th to 12th, 10th, between 9th and 10th. So nerve supply, we know parietal pleura is along with the body wall, so it is supplied by it is derived from the somatopleuric mesoderm. So it is supplied by intercostal nerves and phrenic nerves. And parietal pleura is pain sensitive because it contains the receptors, pain receptors. And whereas the visceral pleura, that is the pulmonary pleura, which is along the lungs, it is developmentally from splanchno-pleuric mesoderm, that is the splanchno-pleuric layer of lateral plate mesoderm. So it is supplied by autonomic, means it is supplied by vagus and sympathetic. So sympathetic and parasympathetic. So parasympathetic is by vagus, and sympathetic ganglia derived from second to fifth sympathetic ganglia. So the arterial supply, just now we discussed body wall, parietal pleura, intercostal arteries, internal thoracic arteries, musculophrenic artery, venous drainage by azygous and internal thoracic veins, lymphatic drainage, parietally intercostal lymph nodes, internal mammary group of lymph nodes, posterior mediastinal lymph nodes, and below from inferior to the diaphragmatic lymph nodes. Visceral pleura arterial supply by the bronchial arteries which supply the lungs. Same arteries also supply the visceral pleura or pulmonary pleura, and venous drainage is by bronchial veins, and lymphatic drainage into bronchopulmonary lymph nodes along with the lung. So these lymph nodes are also located in the pulmonary ligament. So pulmonary ligament, when I was discussing previously, I just said that it contains the loose areolar tissue, it contains the lymph nodes and some nerve plexus as well. So coming to few questions related to pleura, pleural reflection in the mid-axillary line is in space. So mid-axillary line, which one? Can you all guess? Yeah, it is lower border of the lung midway, that is the crosses the 6th rib in the mid-clavicular line, 8th rib mid-axillary line, and 10th rib lateral border of, this is for the lungs. So pleura is 2 ribs below the lungs. So it is mid-axillary line 10th rib and 8th mid-clavicular line for the pleura. And visceral pleura develops from splanchno-pleuric mesoderm, we know that. And what is untrue, we have to say, it has got 3 borders supplied by the phrenic nerves and it is pain insensitive. Can you all guess the answer? So of course visceral pleura is from splanchno-pleuric, that is true, and it's supplied by the autonomic nerves, not by phrenic nerve. So this is untrue. And it has got 3 borders and it is insensitive to pain because it doesn't contain pain receptors. So this completes anatomy about pleura. Thank you.